Hey nurses, this is Kevin with Nursing KAMP.com, and I'm covering my Fishbone course, and the first thing in my Fishbone today is going to be sodium, and we're going to be covering that with the BMP, so let's get into it. All right, sodium, this is part of the clinical book that I have available on Nursing KAMP.com, and you should get it with your membership. If you're not a member, become a member today, and I'm going to basically walk through this book today, and I'm going to talk about sodium, and sodium loves water, and it's all covered in the BMP, the Basic Metabolic Panel, so let's get right into it. All right, so let's talk about the BMP. When we're talking about the BMP, we're talking about this fishbone diagram. And we're going to talk about the first part, which is sodium. And sodium is important because basically sodium loves water. And wherever water goes, sodium is with it. And that's a big concept. And brain is a big issue with sodium. And what we're going to talk about is we're going to talk about the numbers. We're going to talk about what's high and low. How do you fix it? NCLEX approach to sodium, and then pull it all together with the concept. So we're looking at sodium and the numbers. The first thing you want to know is that sodium, I teach that sodium is the only lab value that you need to know, and that is 135 to 145. Now these numbers are important because NCLEX is not really going to focus so much on the numbers. They're going to focus on the concept, whether it's high or low. There's only certain labs that they'll look at numbers and whether you know them or not. Now, but we teach more about like the practice and what's the application of sodium. And that's the purpose of this course, is to kind of look at sodium in the sense of why do we look at it, why do we need it, and what's the point of even monitoring a sodium? Because it is in the BMP, and the BMP is 7 things that are important about the patient. The first column right here is sodium and potassium. Well, sodium is regulated by the kidneys, the ADH, antidiuretic hormones, aldosterone, and I basically think Hopa. And Hopa is the basic process of sodium. It's monitored through the hypothalamus. And hypothalamus is important because the hypothalamus responds to hemodynamics, which means that it's responsible for monitoring blood flow. So the hypothalamus regulates temperature and also regulates osmolarity, which is the second thing. So the osmolarity is important. So when I think about osmolarity, I think osmolarity, remove osmolarity, and say concentration. So whenever you see osmolarity, so high osmolarity would be high concentration. Low osmolarity would be low concentration. So just remove that word. It's one of those weird sort of things when we think about it. But if you just think about osmolarity equals concentration, then you can get to what you need to know. The next thing is that the hypothalamus has the pituitary gland. And that pituitary gland will secrete in response to this low volume ADH, which is antidiuretic hormone, antidiuretic, so stop peeing. And that's basically what it does, is that diuresis is peeing. So what this does, you think about it, it's basically common sense. If a person is dehydrated, they shouldn't be peeing. We want to hold all that water in. So therefore, antidiuretic hormone is secreted and we start to hold on to urine. And that is helped through the aldosterone. And that's the last part. This aldosterone basically prevents any further loss of fluid. And it basically shuts down this process. So sodium is basically regulated through Hopa, which is hypothalamus, osmolarity, pituitary gland, ADH, and aldosterone system. All right, so the first thing we want to talk about is high versus low. And when we're looking at sodium, high is dry. That's the main concept. And the main concept means that it's chronic. And what do I mean by that? Well, chronic means it's not really a problem right now. We usually see that problem way before it happens, and so we kind of prevent it. So chronic things we need to watch, we need to correct, but we don't need to like call the doctor up because the patient is high sodium. What we really worry about is low sodium. Low sodium is acute. And it's acute because, and we'll talk about that, because as a patient starts to go low, so does your patient. And what that means is that as your patient goes down, so does your patient. Your patient gets sicker the lower the sodium. So the higher the sodium, high is dry. So let's take that, dehydration. So we said that sodium is the only lab you need to know, lab value. That's 135 to 145. So when we're on the floor and when we see a high sodium, we think dry. But what do I mean by chronic? Chronic means that the boat is coming. And when we're talking about the boat is, you see a boat coming. And what that means is that if a patient is dehydrated, we're going to basically see that way before the patient starts to show symptomology of it. And what we do is we look at like heart rate. So if a patient is dehydrated, they have a low volume. So they have a low volume, and this is basically vasculature. So there's a low volume, so in response to this, it'll be decreased cardiac output because the patient is dry. And if they have a decreased volume, the heart rate will start to go up. And that's important because the brain over here is responsible for the heart rate in the SA node. And that's important because what's going to happen is the brain's going to say, wait a second, the patient's dry, so let's increase the heart rate. That's why we start to see that's the boat coming. So if a heart rate of greater than 90 sitting in the bed doesn't really quite make sense. So, because a patient shouldn't be high on their heart rate. So that's the boat coming. So high is dry, and that's greater than 145. All right, so what are some of the causes of this? Well, the causes of high is dry actually is the same as low. All right, so let's talk about that, right? They're called the 6 Ds, and that's from here, right? So diuretics. Well, that makes sense because we just talked about Hopa, and Hopa is hypothalamus, osmolarity, pituitary, ADH, antidiuretic hormone, and aldosterone. So that's kind of with diuresis, right? So if you give a lot of Lasix or a lot of things, you can put this patient hypernatremic. You can also put them hyponatremic, which we'll talk about next. Next is diarrhea. All right, diarrhea also makes sense too because loss of fluid, so dehydration. DKA, we'll talk a little bit more about that when we get to the advanced concepts of this, when we talk about diabetic ketoacidosis and anion gaps. Dehydration, right? So you think dehydration on high sodiums. And then drains. Like, what do I mean by that? Well, ileostomies, it could be a NG tube. All right, so let's run through sodium as a fried D5 drag. All right, and what does that mean? All right, so S, salty. Think diet. So diet's very important. So we do low sodium. So low processed foods, all those types of things. Anything that is like fast food, all that stuff, low sodium diets. Osmolarity serum, high. And remember, we talked about that. Osmolarity means concentration. So high concentration, high osmolarity. High osmolarity of Hopa means that the pituitary gland is going to relate to the ADH and the aldosterone, and it's going to try to deal with this dehydration. Diabetes insipidus could be a cause. We'll talk a little bit more about that when we talk about how DKA and but when you think about sodium, anytime you think about sodium, think brain. And brain is the most important. And sodium in brain is acute always. And so when we get to talk about the NCLEX and we're talking about sodium, we're talking about diabetes insipidus and head trauma. All right, so urine osmolarity high, right? So again, urine concentration. Urine concentration high. High concentration means dehydration. All right, so let's talk about the signs and symptoms, right? Well, these are a little bit all over the place if you're looking at different books and stuff like that. So what we tend to think about is fast-like symptoms except for sleepy urine. And what that means is that fast-like symptoms like fever, fast-like symptoms, irritability, fast-like symptoms, increased fluid retention, fast-like symptoms, edema, fast-like symptoms, and except for decreased urinary output, which makes sense because they're dehydrated. Why would you want to increase your urinary output? And that's because of this system again. Or sleepy. They start to get sleepy. So because it has to do with sodium and potassium and calcium, because they all relate together. And that's all about contractility. So when we have problems with sodium, we have problems and the person gets really lethargic or sleepy. Irritability, anxious, which is fast-like symptoms. All right, so D5W for treatment. All right, so I said sodium is a deep-fried rag. Right, the D5 is in there just so you remember that generally with patients who are hypernatremic, we generally use D5, and that has to do with the head injury. And we'll talk a little bit more about that with NCLEX. And, you never ever bolus or use sodium, normal saline, with sodium deficiencies or excess. It's always dextrose 5 in water. And that's generally the treatment. Now, there's a lot of controversial thought process about that, whether, what's more effective and different things like that. NCLEX will stay away from that stuff. But you would anticipate it. It would be anticipated order. All right, so renal failure is a cause of this, and that just makes sense because they're going to be losing fluid. Renal failure. Anosarca is another term for edema, and specific gravity high. And specific gravity, so specific gravity is like specific concentration. So there's another word for us with gravity. So the higher the gravity, the higher the concentration, and sodium high is dry. All right, so what's some other things we need to know about this? All right, so that's it. So that's high is dry. So, they're going to have fast-like symptoms. They're going to, except for urinary output and sleepiness. But prior to that, they're going to be irritable, fever, flushed, all those types of things. So let's talk about what do we do for that? Well, sodium high is you replace it. Okay, you basically deal with the underlying cause. If they're high, we have to look at, okay, is it diuretics being caused? And we hope for that person to equalize. We never really call the doctor at a high sodium because the body naturally is going to regulate this antidiuretic hormone, the pituitary gland, and the aldosterone system. Unless there's problems with the brain, hypothalamus, the pituitary gland, the ADH, if there's pressure up here, it's going to cause problems in sodium because sodium is head and brain. And so if you have a head injury or anything like that, so how do we fix it? We fix the underlying cause. If there's a head injury, we monitor them, and we basically might have a bolt in the head, and we might be monitoring that sodium. So we don't see sodium high that frequently. We might see 146, 147. Generally means, well, what's the heart rate? Are they dry? And are they orthostatic? And that's kind of what the assessment would be. So if you have a patient that is high, let's talk about the numbers. So 145 to 150 is basically assess your patient. Look at your patient. Are they dry? What's the underlying cause here? Are they a head injury? If they're a head injury, then we start to really tread lightly. But that's a different situation altogether. Most likely, we're going to be on a med-surg floor. Did we give diuretics? Are they sick? Do they have DKA? What's their blood sugar? Do they have drains? Do they have an NG tube? What's going on with them? We look at the underlying cause. What's their heart rate telling us? What's the boat telling us? That is the body compensating. Because somebody could be 146 and their heart rate not be high. But if they're 147, 148 and stuff like that, then we start to worry about it. And we also start to look at like other medications like lithium and different things with sodium. All right, so let's talk about low. All right, well, low is acute. And we're worried about low because a patient who's low, it's brain, and that's the issue. Now, this is very complex because low sodium is acute, but the main reason it's acute is because, where's the fluid? And we don't really know what the state of facts are with this patient. Now, are they hypervolemic, which means they have too much fluid on board, or are they hypovolemic, means are they dehydrated? That's the problem with low sodium. So, and that's why it's acute, because we don't really know whether or not this patient is over volume or dehydrated. And that's what we need to do. We need to assess that. So let's talk about the numbers first. So what is low, right? So we have 135 is a normal. So we said normal sodium is 135 to 145. So 135. So let's run the numbers. So 130 to 135 is assess patient. Okay, assess what's going on with this patient. Now, this patient might be admitted to the floor, and we go back to the 6Ds: diuretics, diarrhea, DKA, dehydration, drains, diet. Now, diet tends not to be so much important with low sodium because, patients generally will always have enough sodium on. It's only during excess, high is dry, we start to worry about it. But sodium low is we don't really know where the sodium is, and that's the problem with low sodium. So we want to look at that and say, okay, well, where is the sodium? What's the issue? And so 130 to 135, we assess that patient, and we basically look at these underlying causes. All right, so let's look at some of these underlying causes. Now, remember, when we're looking at low sodium, the real question is, are they dehydrated or are they hypervolume? Do they have too much fluid on board? Now, this is a very complex issue because we don't know. All right, so we need to assess that. How do you assess it? You do something that's called a urine sodium, and we'll talk about that a little bit later. But the principle is that you need to define, is it dehydration or is it over fluid volume? All right, so 130 to 135, assess your patient, watch that patient, look for the underlying causes. Okay, so then 125 to 130. All right, well, that's going to be a little bit more acute. That patient might go to a telemetry floor. That patient's going to be watched very closely, and we're going to be very concerned about this patient because we need to define what kind of osmolarity, what kind of patients are we talking about? Are they dehydrated or are they hypovolemic? What's the underlying cause of this patient? And when we look at this, and what's the main issue? Well, it comes down to this: seizures. Seizures are a huge issue with low sodium. And we don't see seizures until we start to get to less than 120, which gives us our next frame. So 120 to 125. These patients will become ICU patients, all right? And less than 120, we really tread lightly, and we really worry about why is this patient so low. And a lot of times, what's the treatment for this? Well, first of all, figure out what the system is. Are they low? Are they dehydrated? Or are they hypovolemic? So when we're looking at sodium, we're looking at, whoa, slow down, low, it's let's figure out what's going to happen. So we said that the greatest risk is coma and seizures. That's the biggest risk about this, that they actually have so much problems that they get hypo-like symptoms that they start to get seizures. And that's problematic. Diarrhea can be a cause, increased intracranial pressure, also head injury again, because remember, head injury is up in the brain, and the brain is responsible for the pituitary, the hypothalamus, and the pituitary gland, and the pituitary gland secretes ADH. So when you have problems with herniation and what's going on in the brain and the pressure's increasing, remember, if the brain is increasing, there's only so many places it can go. So where's it going to go? And if sodium loves water, what happens is that sodium that loves water, if we bolus that person, pop, they herniate and they could die. And that goes against rule number 1, don't kill patients. So the principle is that when we're looking at sodium low, we're going to really look at first defining whether it's hypovolemic or hypervolemic. All right, so meds, diuretics are the cause. The gravity can be low, specific concentration low, as in a hypervolemic state. So when you think of hypervolemic, you think of CHF, waterlogged patients, right? So think about that. If they're waterlogged and they're waterlogged patients, you're not going to bolus them with sodium, right? Normal saline, right? Because that would cause what? More fluid. And if they're already hypervolemic, why would you do more fluid? They would go into fluid overload, crackles, all those type of things. But if they're dehydrated, that's a different treatment. That's why it's very important to figure out first on low sodium, are they dehydrated or are they hypervolemic? All right, so burns, yeah, mainly because of fluid shifts. It happens so fast. Sodium is mainly outside the cell, right? So when you start to have fluid bursts and the cells start to break, increase of sodium goes all over the place. Ecstasy is just one of those designer drugs that causes increased sodium, respiratory failure, OG tube, and weakness. So you see a lot of carryover between weakness, sleepiness on both sides. So it's very specific as far as, because the issue is with low sodium symptomology, the bigger issue is figuring out whether they are hypovolemic or hypernatremic or hypervolemic. Sorry. All right, so let's talk about it. What do you do, right? So 120, 125, less than 120, seizures, comas. There's a big issue here, ICU patient. Well, what do? We basically will put this patient on a monitor, and we're going to raise them 1 milliequivalent an hour, right, of sodium. And that's important because you don't want to bolus them. You want them to slowly start to rise. Why? Pop, brain. And when you're looking at this is very important because the brain is responsible for the pituitary, ADH, and fluid regulation through osmolarity and through Hopa. All right, so let's get into the next thing as far as the NCLEX is concerned. What does the NCLEX care about with this? Well, the main things the NCLEX wants to know when you're looking at sodium is, there's two ways to think about this. High is dry in symptomology. Symptomology is mainly responsible for high-like symptoms, which we said is fast-like symptoms, except for sleepy and decreased urinary output. So that is high. And when you're looking at NCLEX and sodium, they generally will focus on D5, osmolarities, understanding the osmolarities, and the basic principles of Hopa. And what Hopa is the hypothalamus, osmolarities, the pituitary gland, understanding ADH and aldosterone, and recognizing whether or not the patient is dry or not. And that's what we can recognize through, increased cardiac, increased heart rate, and so on. All right. So what about low sodium? What does NCLEX focus on? Well, NCLEX focuses on fluid overload. All right. They don't want to go into the aspect of, do you know it's dehydration, or do you know it's if it's hypovolemic. They just want you to know, okay, well, high is dry and low is fluid overload. So generally don't ever bolus normal saline. Treatments are generally D5, and that's generally where you're going to be at. They're not going to focus too much on it. They'll focus a little bit more on osmolarity and concentration, diabetes insipidus, and knowing DKA and fluid overload. So when you think of sodium in the NCLEX, sodium low is fluid overload, period. All right, so let's talk about, what about in practice, sodium low? Now, I talked a little bit about identifying, what do you mean low sodium? All right, well, let's take the hypovolemic patient. So this hypovolemic patient has a low fluid volume, right? This goes into the kidneys, and then it goes out into the toilet, right? So where the person's sitting on the toilet, and urinating, right? So now it goes through here, through the PD, right? So proximal to the distal, the loop of Henle, and let's get into it. All right, so you have the brain up here, and the brain with Hopa, and we said the hypothalamus recognizes that this volume is low. So it stimulates the pituitary gland, that releases ADH. ADH works with aldosterone system and slows everything down. All right, so if we're trying to figure out on hyponatremia, what we're going to look at is how do we figure out whether it is low volume or high volume. All right, well, you look at the system. So we're going to look at dehydration. So in a low flow state in a patient, which means low volume going in, right, would they absorb sodium or get rid of it? So think about this. In a low flow state, so there's less blood going into the kidney. So it's going to want to hold on to sodium. Why? Because there's not enough blood. So do you think it's want to get rid of the sodium? No, it's going to hold on to the sodium. So it holds on to the sodium because sodium loves water. So the sodium gets absorbed in a low flow state. All right. So then it goes through here. And so what do you think comes out of the urine? High sodium or low sodium? Well, if they're absorbing a lot of this sodium, out in the urine is going to be low sodium. So think about that. In a low flow hyponatremic state, low sodium, less than 135, if you were to do a urine sodium and that urine sodium came out low, they are dehydrated hyponatremic. Okay? Now, if that sodium came out okay or normal or elevated, they are hypervolemic. But we don't really test that. We mainly look for the low sodium. That's the advanced concept of this. NCLEX will never test you on a urine sodium. All right, so let's pull it all together and wrap it up with sodium and the BMP. All right, so what we're going to look at is this patient right here. And this is my conceptual map when I'm looking at sodium. And you can see right here that sodium plays an important part of it. Now, a person can be walking around and get hypernatremic. Yeah, anybody can get dehydrated. Will they be sitting in a doctor's office? Probably not. They wouldn't be sitting there saying, oh, I'm dehydrated and stuff like that. You know, who would be sitting in the doctor's office and be educated in different things? Patients taking lithium because lithium salts and all that stuff. Could they come into the hospital? Of course, patient in a hyponatremic state and also in a severe dehydration. They can lose a lot of sodium in the hospital because the different treatments that we do, the different medications. It doesn't differentiate between sexes, and age really has no real factor on it. Main thing is hydration and dehydration. The main symptoms of sodium, we already kind of talked about, when we're looking at low sodium, it's more of a factor. So who's the patients that most likely would get it? Well, patients taking lithium will have sodium deficiencies. Patients that have a DKA will have sodium deficiencies or excess, and patients with head injuries. Those are the main concepts. Main complication is high is dry and low is seizures and comas. So we would really worry about patients with sodiums less than 130. That's why we would call this doctor for that. Even at 134, 132, I'll look at the patient, assess the patient, find out what's going on, get some trends, get a baseline of what's going on with the patient. However, high sodiums, we don't worry about high sodiums until we get over 150. But always follow your policy. Would they be on a monitor? Not most likely. We mainly worry about respiratory. Blood pressure, they'll be orthostatic if they're hyponatremic, and also hypernatremic, right, because dehydration. Orthostatic is primary assessment for this. Labs, we might do a urine sodium on a low sodium. However, we'll continually monitor if that patient is low. Less than 125, we really start to monitor their sodiums. Like I said, only raising 1 milliequivalent an hour. Positioning, not really, unless they're a head injury patient. Chest x-rays. Now, if they're hypervolemic, hyponatremic, which means they have fluid overload on hyponatremic, you might think about chest x-rays, those type of things. IV fluids are mainly D5W as the primary treatment. You might also give Lasix and different things depending on. Sodium works with chloride and also with potassium and also with calcium. We're going to cover all these labs in this. Temperature, they'll be high, right? High is dry. Hyper-like symptoms, so hypothermias. Pulse will be high in both of them, hyponatremic and hyponatremic. Respiratory more with low, not high. Blood pressure will be low with hyponatremic and hypernatremic. Mean arterial pressure will be low, and pulse ox not really breathing or oxygenation issues. It's all about fluid status with sodium, and pulses would be weak, thready, or bounding. Cardiac enzymes, nothing. ABGs, nothing. It's all brain. When you're talking about brain, you're talking about sodium. And so always think about them. You only have so much places you can go, and you don't want to pop the brain. Heart, not really cardiac related. Respiratory depression, if anything. The aldosterone with Hopa. Remember Hopa? And that is the main process of sodium. Okay. Surgical? No, not necessary. Will they be discharged? Yeah, they can walk out. I mean, they don't really suffer any, unless they have a seizure or coma. These patients are being monitored in the ICU. Med-surg patients, they can be on that med-surg floor at 130s to 135s. Hospitals are different everywhere. Telemetry, usually about 125 to 130s, depending on your facilities. Less than 130, 125 to 1. Less than 125 is definitely going to probably go to the ICU or CCU. A lot of times they're not transferred out. This is a hemodynamic phenomenon based on this main concept. Well, that's about it. My name is Camp, and this is Nursing Camp, and my name is Kevin, and I'm covering the BMP, and the sodium was the first video of these 7 in the BMP. The next one I'm going to be covering will be potassium, and I'll see you next time. If you have any questions, comments, or otherwise, just put them below and follow me at nursingkamp.com or on Pinterest. We'll see you next time.